All right. Well, we're about 3 after, and just in the interest of everybody's time, we can go ahead and get started. So for those of you who don't know me, I'm Brian Cottonsteady. I'm one of the co-founders of Make Solutions, along with Patty Marshall, who's on the call. And we also have John Schott and Sue Steckley as well from Make Solutions. And I know some of you were on the initial call. I apologize, I was not on that. Well, somewhat apologize. I was at the beach, so I won't feel too bad about that. But I know some of you were on the first call. But for those of you who weren't, I just wanted to kind of give a brief intro to what the CNIO Roundtable is. And one of the things that Patty and I have noticed when we go to different sites is we always get asked, who else is doing this? Who can I talk to that's been through this? But probably the most important thing we hear is, are we crazy for doing this? So what we want to do is bring together different groups. So we have a CNIO Roundtable to discuss physician items. We have one for the PMO. We have one for access management. But we also have the CNIO Roundtable to discuss nursing concerns and questions. And the idea is that it's getting like-minded organizations together that all have Cerner and allow you to talk in an open environment. And I know Cerner does different events that you can go and join that they have, but we felt that not having Cerner involved in the meetings and being able to discuss open and honest conversations with things that aren't working very well, things you've done to make the system work, is important for you. So that's what these meetings are. These are really yours to run and use them as you see fit. The agendas are really driven by you. So Patty will take notes. I'll help. We'll all kind of help drive the conversation, but we really kind of want this to be led by you. So the agenda that you're seeing on the screen now is items that you all have contributed to me, so we can go and put this agenda together.
Hey, Brian, can I interject one thing there?
Sure.
So in the last call, like I think when I prefaced it the last time, Brian had given me notes to use, and we talked about how in the CMIO forum, we did actually have Cerner on a call because we had one whole meeting dedicated to MedsRec. And it seemed like last time, the same as all of the CMIOs were really complaining about MedsRec, it sounded like there was a lot of angst around the use of IPOCs and how useful they were and how difficult they were to use and how all the nurses felt they were duplicate documentation. So I wonder if we should add that on for a future agenda item, and if that might be something where at some point the CNIO forum might want to have Cerner at the table as well, because it sounded like none of you were making good use of the IPOCs, and that both Conker and CAMC had said they both got cited by DNV for their use of plans of care. So anyway, I just thought maybe we could add that back onto the agenda.
This is Tina Stamper. I would love that. We are having issues with MedRec and our IPOC still, so I would really appreciate that.
Yeah, this is Holly from Conker. I think that would be a good discussion. We recently talked to Cerner about the One Plan initiative, and they've talked to us about potentially being a development partner, but I think it's not, I'm not sure it's ready for the stage we would need it at this point to make the leap from IPOC to that new format. We have done a lot of cleanup since our DNV sighting, just in terms of trying to condense various IPOCs into one more generic IPOC for like our surgical area in our ICU, to make it a little bit easier for them to use. But we continue to struggle with it because I think it's not necessarily the intuitive format for nursing, and one that they particularly are fond of.
Maybe what we can do is we can carve out a future meeting to get more into depth with IPOC and MedsRec, and come up with a list of enhancement requests or areas where we think that improvements could be made. And then what we can do is we can get that submitted up through Cerner, and then have them take a look at it, and then they can give a response. And if we like, we can get them on one of the future calls. They've been receptive to that in the past and have said they would love to join some of these in the future. So that might be, I think, something that would be valuable to this group, but then I think more organizations as a whole too.
Yeah, because I think although Tina and Holly have spoken up here, Brent, you said that you guys weren't using it all yet, right?
We do not use IPOC. We have a power form that we created probably in 2007 that we've tweaked after every site visit. They find one or two little things that would be better with it, but it's gotten us through, and it's not perfect. It's not integrated to the problems list or anything like that, but it's gotten us by.
This is Simi from Children's in DC. So we've had IPOC in place for quite some time. However, we have not done any significant optimization or enhancements of IPOC because we were under the impression that they were going to kind of sunset IPOC and replace it. And they had started to demo some potential new applications or workflows to replace it. So I think in addition to just talking about IPOC, it would be really important to understand what is Cerner's strategy for interdisciplinary plans of care, regardless of what it's called, because the current IPOC is very nursing driven. It's not very interdisciplinary, and it really hasn't had a lot of improvement in the last few years.
Holly, that sounds like, is that the one plan initiative that they previewed to you? Is that what?
Yeah, I think that's the direction. Yeah, I think that's the direction they're trying to go with the one plan, is make it more multidisciplinary and carry the interventions and goals across between the hospital admission and then their outpatient follow-up. I think the challenge that I see still being an issue is how to get the other disciplines engaged in documenting in a format in which they see as duplicate documentation, when that's essentially what nursing does every day. So we've struggled a little bit at our organization with trying to get other disciplines to buy in, because it becomes an issue of, if no one person owns it, it kind of becomes everybody owns it, but no one does it. So I don't know that issue is going to go away with one plan, because I think it still requires people to interact with it in that way at a multidisciplinary level. I think it has potential, and I think they're going in the right direction based on what I've seen, but I think it's going to be a phased-in approach of phase one isn't going to be eliminating IPOCs completely based on what I understand. So just to add one other thing that we found at our organization, we went live in December 2017, and obviously educated. We had a homegrown process prior to, so moving to a structured IPOC format in Cerner was a big shift for nursing, and on top of that, they were trying to learn a new system and all the other workflows that they had to adjust to. So we took time after this DNV finding to really re-educate our super users and leadership at the department level to really understand the system functionality and how it can work for them, because although they're not ideal in terms of the format that Cerner uses, I think there is some kind of key education points that were missed in our implementation because, like I said, people just had so many things to learn. So just in doing that, we found that we were able to kind of make some progress, and that also helped those super users help to identify some potential design opportunities for us to do in the interim before we get to one plan. We certainly didn't want to redesign all of them or make it a massive project, but I think just making some small changes was some quick wins for staff.
That's great. Thanks, Holly. Anything else about IPOCs? I mean, we could probably make that the conversation for today if we wanted to, and then capture some of those particular items that we are looking into, or do we want to take that as a follow-up and try and get a little more information about what future items are or what the future roadmap looks like, and then come back to that.
It may be,
Right,
sorry, this is Molly again, it may be helpful to maybe do it as a future just to get a little more info from Cerner.
Okay.
About the direction. That's just my thoughts anyway.
Okay, so we'll work, see if we can get some additional information on what that roadmap looks like. And then we can maybe put together some of our thoughts. And if there's, like you said, Holly, if it's still sort of in the infancy stage, the one plan, we might have some ability to make recommendations or help guide where that tool is going. All right. So since we do have a couple new sites, I wanted to allow them a chance to introduce themselves and make sure everybody is aware of who they are. So Patty, Spina, or Simi, did you want to actually let you both do introductions and for Children's National and the Bear Institute?
Sure, I wasn't sure if Patty was on or not, but I'll introduce myself. My name is Simi King. I'm the nursing director for clinical informatics and professional development. So my scope is actually all of nursing informatics as well as nursing education, professional development, and our interprofessional stimulation program here. I've been in my role since 2013. And Patty is the healthcare executive for the Bear Institute side. So I'm not sure if you are familiar with the unique relationship we have at Children's, where we actually have a pediatric institute for innovation and technology with Cerner here on site at Children's National. And there are Cerner employees dedicated to Children's National who work here on site. And so that partnership is part of what we call the Bear Institute, and Patty is part of Bear Institute, and I'm an employee of Children's National. However, we work very closely together in our respective roles.
Hi, Simi. Patty's on too. Thank you. You said it perfectly.
No, I didn't see it. I'm sorry.
You said it perfectly.
Great. Thank you, Simi, and welcome to both of you. Lori Myers, I don't think you were on last time. Do you just want to do a quick introduction to yourself as well?
Sure. I obviously work here at Covenant with Tiffany and Chris, and my role is kind of a hybrid role in that I spend most of my time working with quality and regulatory folks, making sure our chart meets the quality and regulatory needs of the organization.
Great. Thank you, Lori. And I think, Tina, we said this is your first time as well. Do you just want to do a quick introduction too?
Sure. Thank you guys for including me. I do appreciate it. I'm Tina Stamper. I work for Charleston Area Medical Center in Charleston, West Virginia, and I am the director of nursing practice of innovation and informatics. I have a dual role where I am the bridge between our practice and our EHR. So I do all the policy, procedure, documentation, and make sure all of those are in alignment together. Great.
Well, thank you, and I appreciate you joining, and everybody for taking time out of your day to join here. So a few items that we had on the agenda today. Lori wanted to discuss pain assessments and reassessments, and then Brant had a couple items as well, nursing communication tools, how we do communication between nurses, wireless vital signs integration using Vital Links, and then they're also getting ready to go up on the Cerner 2018 code upgrade. So I thought that might be good for all the sites who've either gone through it or are planning to go through it, just to share lessons learned and give Brant in Tennessee Medical Center a little bit of input on what they have done. So Lori, we can come back to you. Did you want to kind of set up where you are with the pain assessments and reassessments and what you're looking at?
Sure. We are currently in the lovely, probably 9-month process of having Joint Commission hit all of our hospitals. And as they do with IPOCs, they are hitting us hard and heavy on pain assessment and reassessments with interventions. And we've had several requests from our nursing staff to get more of the documentation. Currently, we do our assessments in iView. We acknowledge any pain scoring, et cetera, we may have done on the, I'll just say MAR, but you all know I mean MA. But they have asked, is there a way that we can move that out of the assessment out of iView onto the MA/MAR so they're only going to one place? Also couple that as we hope to be able to use our TC51s for this pain assessment, reassessment sometime in the future. Just wondering what folks have done that has been successful, that those regulatory bodies have actually said, wow, that's good work.
This is Brian at UT. So ours are mandatory fields within the MAW. It's also in iView, but we don't task the pain assessment. So, because if you did a pain assessment task and it was higher than 4, it's automatically set to fire a reassessment. But that assessment is going to lead to you going and getting a medicine and giving it. So they document the pre-score in the MAW, and then if it's a PO, they'll get a PRN response in 60 minutes. If it's IV, they get a PRN response in 15 minutes. So that they get out of that loop of assess, reassess, and it never goes away. So we don't have a task to assess pain, and if they don't give any pain medicine on their shift, then they're supposed to go directly chart what they assessed and what the score was in iView, because it was the same thing here. It was just constant. A loop that you can never get out of. We also have 3 or 4 selections in the PRN response that will keep them from getting another reassessment task. So if it's pain is acceptable to the patient, if they're back to baseline, if they're like a chronic pain patient, there's 2 others I believe that won't fire the reassessment task, and it basically closes the loop. So once we instituted that, it seemed to work well. The ones we worry about is if they're not given any pain medicine, that they've got to go do at least 1 pain assessment per shift to say that it was addressed.
So it sounds like you have successfully given them basically one place, and instead of having, let me document it in iView, go grab my med, do my mom, then come back. So,
right. So it's mandatory in the MAW. So it's all those pieces of what scale are you using, what's the score, is it constant or intermittent, where is it located, and then we also use something like a sedation scoring at the same time. So what's their respiratory rate, what's their alertness, and then those are pieces of the reassessment on the PRN response as well. So we constantly tell them, you got to have a pre and you got to have a post. And if you'll do it, mandatory fields in the pre, at the medication administration, that takes care of the pre. If they'll just complete the PRN response test, they'll have a post. And the only one I said we're concerned about is the patient that doesn't get any pain medicine during the shift. They've got to at least document that they assess their pain once, and just do that directly in iView.
What we did at CANC is we launched a power form. We have too many various pain scales from the patient populations, from our NICU babies to pediatric to adults to our intubated patients. So we had to launch when you scan the pain medicine, it launches the power form that provides you all the documentation that you need, and then you're able to go through the MAW and complete your process. And then we have the reassessments like you discussed that launch 30 minutes after the pain medicine has been administered.
We folded those into the MAW, so there's a drop down for if it's a scheduled medication and then there's an NA for the NICU, because some of those babies are getting scheduled morphine, and so it's a little more clicks for them, but it worked at our last survey, so we've kept it that way.
Do you care to send me what it is that you all utilize? Because we couldn't make it work, and that would be better. That's one less power form to open up if it's incorporated within the mall.
Sure.
I would love that. Thank you.
Any sharing would be appreciated here at Covenant.
Grant, if you just want to send it to me, I can send it out when we get the minutes and everything put together. Lori, did you have anything else on that you wanted to ask?
Nope, that will get it. I appreciate it.
All right. Thank you. Grant, you wanted to talk about some of the nursing communication tools, and we talked in the Volt or the CareAware Connect or the TC51s, as Covenant calls them, or Voceras.
We're in the process of evaluating. Volt was purchased by Hillrom. We have Hillrom call system, so there's an integration and a partnership there that we're trying to learn about. We've got the demos several times on the CareAware Connect, depending on which device you want to use with that. You know, and just wanting to see what other people have gone to, if they stayed within the Cerner communication tool, or if they've gone to another company, because I think it's one of the last remaining technological advancements that we want to provide for the nurse at the bedside. And I think if we do it right, and it gives them one tool to do many things. But I don't want to reinvent the wheel if somebody's already done it and there's something out there that's working well. I mean, Cerner tells you it works well, but.
Hi, this is Cindy. I'm happy to talk about a little bit about CareWork Connect. So we're an early adopter back from 2014, and I've led that implementation through to our second our optimization back last year in 2019. We originally adopted the CareWork Connect platform on the 2.0 platform using the iPhone, and at that time, our primary users were nurses. We had also incorporated it to social work and respiratory therapy, and some small provider groups, including anesthesia and NICU at the time. We had challenges on the 2.0 platform. Connectivity challenges related to either the application, an app that was not very stable and required some upgrading, iPhone devices that challenged us with the iOS upgrades, as well as Wi-Fi connectivity issues. We subsequently went through a huge process of whether or not we were going to stay on CareWork Connect, and did a lot of end user engagement and stakeholder buy-in to determine if we were going to move to a different or alternative product, or if we were going to continue with looking at how to optimize Connect. And subsequently, we basically decided to move forward with Connect, moved forward with the 3.0 platform in March of 2019, moved from an iOS device to an Android device, and we are on the TC51 at this time. We use the TC51 with the built-in barcode scanner in it. And as of March of 2019, we have not only transitioned all of our previous users from 2014 onto the current platform, but we have had a deployment of the devices for shared devices across our hospice service, our resident service, our ICUs, our pharmacy, our ED, our perioperative services. We have also, in recent months, due to COVID, expanded the use of PowerChart charts only on iOS, but that's through BYOD, but camera capture, as well as BYOD Connect Messenger, and provisioning Connect users as needed. So for us, Connect has gone well in the last year. We've found new use cases for it. We've had very limited crash reports since we transitioned to the 3.0 platform, very good user feedback, and now we're continuing to look how to leverage, given the nursing app in Connect has now been optimized to some degree and become more useful, and now we're looking at how to utilize that in our workflow and are looking forward to a demo with Cerner, as well as looking at barcode scanning, where we use Bridge and Timeless here for blood and specimen and lab, and for breast milk Timeless, and are moving to Cerner lab. So just quite a few different things for barcode scanning before we decide to move forward as to what will look like.
Yeah, this is Chris here at Covenant. That's pretty similar to our setup as well. We use the TC51. In some cases, we've gone to TC52. But yeah, that seems like a pretty stable piece of equipment. We are contracted kind of for the hot swap, which seems to still be more cost effective than life cycle. So, you know, if one breaks, we send it back to Cerner and they send us a new one. So we keep a small part level of those. But the only real issue that we had with stability was really around there's some Google Cloud dependencies. And so we did some work with Cerner to reroute some of that back through Kansas City instead of Google. So in some instances, you know, if Google Cloud is down, we're still up. But same use cases. We're using it for barcode scanning. We're also developing a lot of our internal applications, some homegrown development, you know, to be mobile. So we've got some hand wash screening, we've got some visitor screening and things like that we're dropping on there just because, you know, it's a great platform for it. We don't use it for call light integration, although we're kind of staging to that. We're dragging our feet a little bit just to kind of see where the technology goes. But, you know, in some instances, we've had a pilot where, you know, the nurses wrote down their individual CareAware Connect phone number on the whiteboards, and the patients, you know, use those. So in some instances that works okay, but obviously call line integration would be a little more seamless. We do push pretty hard the desktop version as well. So we'll evaluate if, you know, a user may be more prone to be at a desk location, for example, pharmacy, pharmacist managing, you know, the in-house pharmacy, for example, really lends itself to the desktop application. So the nurse, you know, can be mobile and text the pharmacy down there and get a response back. So in some instances, we'll use CareAware Connect as a license more than we would, you know, connecting it to BYOD or, you know, a TC51 or TC52. Then, you know, to Lori's point, you know, part of what we're looking at is, you know, our nurses love going in and, you know, passing those meds, you know, with that device, but we'd like to get more documentation pushed into, you know, that application as well. So we're kind of pushing for, you know, lab scanning, blood scanning, as well as, you know, entering of vital signs and potentially assessment. So, you know, that's one area. The more folks that got on it and pushed, you know, that would be a bigger help for us. Just again, like I said, we're pushing basically any internal development, you know, to be built for a mobile solution.
This is Simi. I would just add about the desktop messenger, just to add, we actually realized during COVID-19 that desktop messenger was extremely helpful for the nurses who were in a patient with a COVID positive patient and did not want to leave. They would actually just use desktop messenger to send messages to their observer and or to the other nurses who were out in the hallway if they needed something, so they didn't have to doff off their PPE and come out of the room. So I agree with you. There's some real novel use cases for desktop messenger given our current environment, as long as staff have accessibility to a computer or a laptop in the room.
This is Holly. I just have a few questions. At either of the sites where you're now using CareAware Connect, were you previously using Vocera or another hands-free tool? I'm just trying to evaluate how the nurses did with the transition of a hands-free to now carrying a device, and have you had issues with that or complaints around having to have something with them at all times?
So this is Simi. So when Children's National opened their new building in 2007, we transitioned into that new building with ASCOM phones. And so our nursing staff were already accustomed to getting phone calls, getting text messages, and getting physiological alerts, as well as nurse call alerts on a mobile device. And we transitioned with that same, with those same features onto the Connect device when we moved to the Carework Connect platform.
And this is Chris. We went up at 8 facilities with this technology. They had a plethora of different communication tools, none of which were really Vocera, but they had walkie-talkies, cell phones, pagers, just the whole plethora of different items. But really what we found through our needs assessment was, kind of like, the push of the original iPhone. They wanted to be able to make calls, and then they wanted, to be able to make text. And then the more applications you put on there that were beneficial, that's what, our newer generation of nurses were looking for. They were really looking for a handheld piece of equipment to do more with. And so hence our push to get, more assessment, and documentation tools kind of built into that phone. But just med administration, in itself, basically kind of nixed any hands-free. They were really willing to, give up anything else to be able to pass meds. And like I said, as we push more and more apps to mobile, they're, they always have 100 different use cases for different things we can, put on the phone. Now we do manage it through AirWatch, so we don't let folks just download apps to the phone, but we've got a pretty stringent change control process on what gets added. But we've just slowly been adding, Cerner and non-Cerner applications to the device, that are specific to nursing, transport, pharmacy, case management, camera capture, all those different instances of use.
Are either of you using it, and you may have stated this, but are your providers also using the CareAware Connect platform on a phone? I'm just interested to see if anyone's utilizing the technology to communicate between the care team, and if you are doing that, is it are you using an assignment-based driven functionality to identify which provider has which patient?
This is Chris. Our providers do use it. We're actually in a process right now of kind of advancing to bring your own device. But similar, our anesthesia was an early adopter. Is a great use case there. There is a bit of a challenge if you think about it. Most of the time, it's the nurse initiating that first touch back out to the physician. And so a lot of times, it's the nurse getting the physician's number or looking them up and, texting them in through Connect. And, we've got a process where, the physician then can just reach directly back out to the nurse. We have done some ideas and requests back to Cerner in that the docs, when they look up the nurse and the workflow that you described, they look the nurse up and the care team and see who they are. Then they've got to come out of that app and go into CareAware Connect to text them. And what our argument is, we want to jump from, it's nurse X in the care team, and boom, I can click there and go ahead and connect to that nurse, via their TC51. So that would be a lot more seamless. That's probably the biggest complaint we get from the docs is, I go get you know, which nurse is taking care of this patient, and then I've got to go in and connect to send the message. It's not that much different than finding somebody's name on a spreadsheet, you know, and then going in to text them. But, you know, consumer ease of use would really make it to where I can just click on that nurse and, you know, it would jump to CareAware.
Hi, yes, so this at Children's, so we also use the Clarvia Patient Assignment Manager. And so we do have a whiteboard that is visible at the front of the unit. And so the providers can look up on the whiteboard what the nurse's extension is. We also have an integration with an app called Roundabout that one of our providers here created, helped develop, and it is part of Millennium. And inside Millennium, on their list for when they're using Roundabout, which actually was used to help facilitate nurse or parent presence at rounding, they can directly text message the nurse from the Roundabout application to let the nurse know that they're going to round on their patient shortly. So that's one way to connect during rounding. And then also for nurses to connect with people who are in roles. When Cerner was when we first implemented Connect back in 2014, they didn't have this role-based concept. And so we created generic roles and people logged in these generic roles. And so you wouldn't have to know that Simi was the charge nurse on a particular unit. You would just look for the charge nurse on that particular unit. So since then, Cerner, and we had worked with them at that time, and I know that other facilities have also partnered with them to really build out the concept of role-based. And so now all I have to do is look up a PICU attending or the ED social worker, and I don't have to know what their name is as long as the role is claimed. And so I can send a message to that person by role, including the unit charge nurse on any one of our area charge nurses, because they've claimed that role, including our night supervisors and other individuals. So that does help facilitate the ability to connect with the right person, even if you don't know what their name is. And so those are other ways in which you can have a full care team being able to be accessible throughout that whole communication ecosystem.
Yeah, this is Chris. I would fully agree with the role assignment. You know, going in and accepting that charge nurse role. That was kind of our first step. You know, in turning a facility on. You know, that made it easy to go around, get that charge nurse on, and then say, hey, just look up the charge nurse. Go ahead and send them a message. And you know, we kind of make rounds through the hospital that way, and that kind of got folks interested really quickly. Also, we got rid of that charge nurse phone and pager.
Anybody else have anything else that they want to talk about for the nursing communication tools? And Brent, you're also wondering about the wireless vital signs using Vitals Link.
Yeah, getting the nurses a phone and getting the techs a wireless vital signs device, Dynamap, whatever y'all are using. It's kind of like the last two pieces that kind of keep hanging out there, and I didn't know if everybody else had their vital sign devices routed wirelessly so that those information on that patient's getting right into the chart, you know, for say St. John's sepsis to pick up something earlier, or you know, that it's not sitting on the napkin for 4 hours before the tech puts it into the system. We evaluated them a couple years ago, and we felt like we were going to go stay with Dynamap and go to their Dynamap VC150, which is a wireless version. And any new ones we purchased the VC150, but until we replace the entire fleet, we're not going to connect any of them. So I just wonder what everybody else was doing.
Well, this is Chris. Our interim move has been since we've been pretty successful with the CareAware Connect application. One thing that we've done is try to get most of the care team involved. So getting phones to the techs was, a pretty big part of that for us this year. And so just a little bit on the cheaper side, and we're kind of in the same situation you were there. We're just implementing that vital signs data entry on the mobile device. So when the tech's in the room grabbing those vital signs, they can go ahead and just enter them right there, with the handheld. So that's kind of our interim step, while we're kind of working to replace, equipment across, 8 hospitals.
Mm-hmm.
This is Holly. We do have device integration set up in the majority of our areas, and I would say it works well. We have Philips monitors, so we've worked with Biomed and integrated those within Cerner. We do have the St. John Sepsis Advisor, and there is a confirmation process the nurse has to go through to kind of pull the vital signs in so that they're not accepting erroneous values. But I would say for areas like our PACU, ICU, post-cardiac procedure areas, it's definitely a necessity. When it is not available, it's not a good day for us.
Yeah.
So the tech's vitals aren't validated as soon as they hit the chart. It's still waiting on the nurse to validate them, kind of like they come in from BMDI.
Yeah, and I can confirm that with our analyst, how we have that set up, and how that functions with our sepsis advisor. So I'll try to get an answer for you while we're on the phone on that one. But that's my understanding. So let me see if I can get that answer for you.
Hey, Brent. I mean, you guys have BMDI in your ICU.
In our ICUs and in our step down, yeah.
Yeah. Okay. Yeah, I thought so.
We're going to expand it to the ED next month, and then NICU following that, and then some other floors that kind of have monitors, like they have maybe a small part of their floor is considered a step down, and they have bedside monitors that we were going to map in.
Yeah, I mean, that's the same for us. We're kind of on hold for the ED, just with, some of this reduced volumes, but definitely for med surge, we're just we've been weighing that cost benefit kind of thing for a while.
Yeah, I have to look at it if that works for y'all, and you choose not to go with a wireless vital signs device, but you've got the handheld that they enter them directly. Just the workflow with the wireless device seemed better for the tech. You scan the patient, they scan themselves. When they're done taking the vitals, they hit send, and they become part of the patient's record through VitalsLink as validated data. So to hear that somebody's doing a non-validated, potentially, I mean, the nurse, those vitals, if they're abnormal, will go to the nurse for review via CareCompass. So I don't know that we would want to do it unvalidated, because it just it would slow it down, in my opinion.
And I may be thinking of Alaris pump IV documentation, so I'll confirm that. I certainly don't want to confuse the issue. I just sent a message to one of our analysts who supports that.
I mean, I've heard it both ways, and when we were, doing BMDI, we were doing infusion management, and both of those come across pink or purple, and they're waiting on the nurse to validate. But I was under the impression when we went through VitalsLink, it would come across as validated.
Anything else on the VitalsLink? know, Holly, you said you're going to try and find some information there on that one as well, so we can get that out to the group. So the last one I had on here was the Cerner 2018 code upgrade. Brent, I believe this is what you said you were getting ready to go up on. So were you looking for feedback from the group?
Anybody else upgraded to? I put it in our when I sent back to you what our current. I updated all of those. And what is it? The site info spreadsheet.
Yeah, I updated the site info
yep.
when you sent it. Yeah.
Yep, 2018.01.05 is what we're at, and we're going to 2018.03 on the not this Saturday night, but next. So I didn't know if anybody had already done that. Or if we were
I think you might be bleeding edge there. Yeah.
Pig.
Is that a release that has enhancements, or is that just correction fixes? I haven't read enough about that one.
I don't think there's a whole lot of change in functionality for at least the nurse. I did a lot of testing on it. And I cannot recall what the benefits are, but we hate to stay behind, because we did that for a period of time in our history with Cerner, and it's just terrible trying to get caught back up. So trying to take it once or twice a year and stay up to speed.
That's an impressive timeline if you take it once or twice a year. Are you using the upgrade center?
Twice may be a little full, but
okay.
You know, we were having this, having to have a downtime in the fall for time change, and then a downtime in the spring for time change, and then a downtime for the code upgrade. But I think we've finally, with the last code upgrade and going forward, we can upgrade on one node, switch to users that never even know it, and then upgrade the other node, and we don't have to have a downtime. And I don't think we have to have downtime anymore for the time changes. So that's an improvement.
Yeah, it definitely is. I think a lot of that came with the 2018. I don't know enough about what came in the 2018.03 release, though, to be able to help you out with that. I know Conker just went up on 2018.01, maybe 09, I think, a few months ago. So they're on a little older version than you, I know. I'm not sure where the other organizations are.
So I'll be able to report back how well, not well, it goes next, not this weekend, but next. But so.
Absolutely. Yeah, I mean, if there's any lessons learned, certainly, I'm sure the group would love to know before they run into them as well. Somebody's got to be the trailblazer.
We normally aren't. We normally let everybody else work out all the kinks. Well, we've been with Cerner since in the 90s. And so being with them for so long, and then them changing to standard content about 2010, we're already 11 years into totally customized system. It makes it hard for us to just plug and play.
Yeah, we just went to 2018.01, I think, .11 is where we're at. But yeah, the time change stuff came with that, I think, 18.01.
Yeah.
So it's funny too how soon everybody forgets. They're like, "What did we get out of that upgrade?" It's like, well, you don't have to have a downtime. It's like, oh, we forgot about that downtime during time change. Hey, I did have one other question. That I know there was a mention of Blood Bridge. Is anybody using the mobile, any mobile version of Blood Bridge and scanning there? Lori, I know you and I talked about, I think you found that there was an app for mobile.
That's what I have been told.
Would
As
it
a
be the
Cerner
other-
solution?
Yeah.
Right.
Is the use
Bridge.
case that they would use
Is
the
it
handheld?
integrated with CareAware Connect? Is that what you're asking? Or
Well, in the App Store, you know, a mobile version of Blood Bridge, so you can utilize a TC51 for scanning of blood and documentation.
we don't. I mean, well, obviously we don't even have a device, but I mean, we
Yeah.
we don't have Bridge, but we've asked for it
Mhm.
at least for blood, and then eventually breast milk, but because that's one of the things we do on paper and with Joint Commission. Have y'all had Joint Commission yet this year, or y'all not scheduled for this year?
Lori, you want to take that one?
Yeah, we have had 6 of our, or let me say 5 of our 8 hospitals have been through Joint Commission this year.
Yeah, we're about overdue on our 3-year. I think this is the month they came 3 years ago, 2 years ago, 3 years ago, I think. And so I don't know what they're going to do now with COVID, but I think they will give us a little heads up. But we're expecting them at some point here.
They started making calls 2 weeks ago, giving folks the, hey, we're coming to see you soon.
And blood was one of the ones last time when they were here, because it's on paper. You know, anything on paper, there's a potential for doing it wrong. Because if you don't fill out all the blanks, then you weren't compliant. You know. So.
Yeah, I mean, for us, Bridge works really well. I mean, it was a little tricky from an implementation standpoint, just in that, you know, there's a lot of barcodes involved, and surprisingly, you know, you can just scan the wrong one in so many different ways. And I know that sounds comical, but really, I mean, it for some reason, you know, between the armband and the blood armband and the bag, it's you have a couple of issues. You got to walk them through a few times before it sinks in. But, you know, like I said, for us, we're trying to get as much on that mobile device as we can.
Right.
You know, we had heard there's an app, you know, and just wondered if anybody was using it.
We can ask out to the larger roundtable community as well and see if anybody responds back.
Okay.
You know, there's a few organizations that aren't represented today, so we can see.
What was the question around meds rec? For the providers or for nursing or some type of pharmacy med rec doing the home med list?
Some of it's with transfer med reconciliation. How do other organizations reach compliance for their transfer med rec? And the complete function, we don't find that it's, we find lots of errors with being able to complete.
Having the ability to complete, like wiping it off the list?
Yes.
Yeah, so a little note on that is a couple years back, the pill bottle, the prescriptions on the list, we were completing those and converting them to scrolls as a home med. But when we brought up clinics on PowerChart, that created a problem because you were wiping it off the list. So then we re-educated. You just document the compliance unless they tell you they are no longer taking it, the doctor took them off of it, then that's the only time you would complete it. And because when they got it back to the office, they didn't have the ability to, renew it or send another script from it. So we had to educate on that piece. And
we're only using Complete for short-term medications, your short-term antibiotics for 5 days, using it for your small, like steroids, your tapering doses, and the patient is not taking it because they were taking it for 5 days 3 months ago. And they're finding that they can't complete some of those as well.
They can't?
Yeah. I think what we found on a couple, somewhere along the line, somebody may have entered the information and didn't put the dose or the route on there, like it was started on the med history, and you can't complete that.
I'd have to play with that a little bit. The other thing is we don't really do a transfer med rec, like in-house, going from the ICU to the floor or the floor to the ICU. I don't think we hardly utilize the transfer med rec at all.
No, we don't really either, and we would like to get some compliance, and we're not sure what other organizations do to help.
We do have partial med rec, so for consulting services, the cards is consulted, they can go ahead and reconcile and even do a partial discharge med rec on those meds they want them to go home on and not do the whole thing, which then allows the hospitalist or another group to go ahead and finish it out at the end. So we do have partial med rec turned on.
So we are right here at time. Is there anything that anybody wanted to bring up here before we have to jump off? Great. So just a reminder, our next meeting will be September 9th. I'll get an agenda or a calendar hold out for that as well. Patty Marshall has been great at taking minutes for here, so she'll work on getting the minutes out, and then we'll send that out along with any other materials that we want to send with this as well. And then for next meeting, we'll work on seeing if we can do some more work around the IPOCs, meds rec. And then I thought if we wanted to talk about downtime planning and preparations and how organizations do that as well, we can maybe get into that, although those may be two separate discussions there that each take up an hour. But we will work on that. So thank you, everybody, for joining today. I think this was a really good meeting. Hopefully it was valuable to you as well. And we look forward to talking to you in a couple months.
Thank you.
Thank you.
Enjoyed it. All right.
Thank you, Ron.